Hello and welcome to Illuminating Health, the UCSF School of Nursing's podcast that sheds light on health and healthcare issues affecting our daily lives. My name is Monica Corbin, and I'm currently a student in the BSN entry to DNP pathway in the psychiatric mental health nurse practitioner specialty. And today I'm joined by UCSF School of Nursing Associate Clinical Professor and my own incredible mentor and supervisor, Kate Molino. Thank you for joining today's episode, Kate.
Thanks, Monica. I'm so happy to be here.
So, today we'll be discussing a topic that doesn't get a lot of attention: the mental health of older adults, particularly older adults living with serious mental illness. One lesser known and really striking statistic is that Americans with serious mental illness, such as bipolar disorder or schizophrenia, can have a life expectancy that is 10 to 25 years shorter than the general public, which would mean that for many individuals, senior age may begin as early as 55. Kate is a nurse, educator, and researcher whose work centers on improving mental health care for older adults and adults living with serious mental illness. She recently completed her PhD in nursing in 2025 and was also named a 2026 Macy Faculty Scholar, a prestigious national leadership program for health professions educators. Her research and teaching focus on advancing mental health equity and preparing future clinicians to provide high-quality, compassionate care to older adults with serious mental illness. Kate, to start us off, can you tell us a little bit about your work and what drew you to focus on mental health in older adults? Maybe there was a moment with a patient or in your training that really shaped this path for you.
Monica, thanks so much for that very kind introduction. And I'm happy to talk through this with you. I would say that my interest in working with older adults arose in phases that have really unfolded throughout my career. At this point, I've been a registered nurse for 16 years and a psychiatric mental health nurse practitioner for 12. And I have worked for that entire time in mental health in a variety of settings. I've worked in psychiatric emergency care, acute inpatient hospital units, outpatient clinics, integrated primary care, including HIV care, and currently I work in an interdisciplinary house calls team for homebound adults. And throughout this time, I have worked with so many older adults that have piqued my interest. When I was an inpatient RN on the acute psychiatric unit, I had many patients who were on the unit for months who I worked with as their primary nurse. And they were elderly and often stayed for a long time because they required special placement needs in order to really make sure that they were going to be safe and well after discharge from the hospital. So I really got to know these people and I got to know their stories. They all had different diagnoses. Some had bipolar disorder, depression, others had schizophrenia, and some had cognitive impairment. And one thing that stood out to me was that their care really required the input of a lot of different clinicians and the interprofessional team. So the folks I was working with not only had symptoms of mental illness, but they were dealing with a lot of physical illness. They were dealing with a lot of social challenges, with isolation, maybe lack of family support. And I took the lessons that I learned working with these folks when I completed my final nurse practitioner clinical residency year at a mental health clinic in San Francisco that was specifically geared towards serving older adults with serious mental illness. This also, again, translated into my work in the community. I just kept working in these spaces where older adults seem to be overrepresented, and even in places that you may not expect, like the psychiatric emergency units or in the HIV primary care clinic. And so this really evolved over time. And I would say that I think working with older adults is exciting because of its complexity. It's very complex in terms of the knowledge that you need to have and draw on, and the decision making that you need to engage the patient, their families, and the rest of the team with. You have a lot of opportunity to discuss goals of care and maximizing quality of life with your patients. And you really get to draw on your team members, which honestly is one of my favorite parts of working in healthcare, working with my amazing interprofessional colleagues.
Oh, amazing. So, yeah, just listening to your answer, you obviously have a very wide range of experience that brought you to caring for elderly population in mental health. What stood out to me, one thing that stood out to me in your response is that the complexity of the older adult population. That does bring me to the next question I wanted to ask, which is that when we talk about mental health in older adults, what do you think people most often misunderstand?
One thing that immediately comes to mind, and Monica, I think this really dovetails with what you just said, is often older adults, or at least the generation who are currently older adults that we are working with, may not really resonate with the idea of mental health as younger folks might think about it, or may not talk about what they're experiencing in these mental health terms of depression, anxiety, or other concepts. So, in my experience, and this is also supported in the literature, often older adults talk about the symptoms they are having as more physical or somatic. So they are experiencing a lot of sleep disturbance, a lot of fatigue, appetite changes, often pain. And so we need to be able to be aware of that when we are working with these patients. I also think that often there is a misunderstanding of what is involved in what we would consider normal aging and how we can separate that out from what we might call mental health concerns.
Why do you think it is that elderly patients might discuss their symptoms more in terms of their somatic experience rather than describing more mental health related concepts that are maybe more familiar in the younger population?
One important consideration is that often these folks grew up in a very different time, and those of us who are younger, who are on the internet, we are exposed to so many different ideas and so many different frames of thinking that might not have been available when these folks were growing up and really starting to internalize internal self models or models of self. And I do also think that stigma, while it certainly is alive and well today in all populations, mental health and mental illness was even more stigmatized, when these folks again were growing up, and in terms of what they learned about what was okay to express and what was not okay to express. So to me, this plays a big role in it. I've often visited folks uh, who I've introduced myself and I've said that I am the psychiatric nurse practitioner. And I often want them to know who referred them to me and why. So I might say something like, your primary care provider asked me to come and visit you because they think that you might be having some symptoms of a mental health condition that I could help you with. And I've had many patients say to me, you think I'm crazy. I'm not crazy. And I don't think they're crazy. But it's that sort of mismatch in what do these words mean? What do these concepts mean? And I think this is a big reason why older adults tend to express themselves more in terms of physicality.
Absolutely. That makes a lot of sense. Yeah, the concept of mental health is something like as a culture we're developing more awareness of.
Absolutely.
Well, at the top of this episode, I mentioned that people with serious mental illness can have a significantly shorter life expectancy. Can you help us understand why that is?
Sure. And as you mentioned at the beginning, we know that people with serious mental illness, and when I say serious mental illness, I'm speaking specifically about folks who have mental health conditions like schizophrenia, bipolar disorder, severe depression, or severe PTSD. On average, they do have a life expectancy that's significantly shorter than those in the general population. And perhaps the assumption might be that this is because of a higher rate of suicide or higher rates of substance use and perhaps overdose, which is true for this population. This population does have higher rates of these things. But actually, the research shows very clearly that the strongest reason for this reduced life expectancy has to do with poor physical health. And physical health and mental health are so closely intertwined on many levels. So, having a serious mental illness might result in people being less able to care for themselves physically, which includes things like getting timely medical care, eating a healthy diet, or exercising, because their symptoms can impede them from doing these things. And then, even when people want to get medical care, their symptoms might be severe enough that navigating, making an appointment, getting on the bus, signing into the visit with their providers is really tough and ultimately too overwhelming. So, this population also is faced with significant diagnostic delays, which, of course, then in turn affects their ability to be successfully treated for these physical issues. And then, on a more structural level, having a serious mental illness makes it much more likely that you will be living in poverty. And this doubly constrains things like access to healthy food or perhaps living in a neighborhood where you feel safe to walk around. And we also know that living in poverty creates biological stress on a human. It affects us at a very biological level. Additionally, providers might be less inclined to take these patients' physical complaints seriously or at face value. And then the third piece of this is that the psychiatric medications that we prescribe themselves, while we do it in order to provide benefit and relief for our patients, they are not without side effects and risks. And many of the medications themselves can predispose people to developing various metabolic problems, diabetes, cardiac disease, and so on. So it is really a multifactorial issue.
Right. And yeah, I was just thinking that was the word in my head, multifactorial. Just thinking, you mentioned social determinants of health playing a role, the effects of medications that are just a part and parcel of the medication treatment, the barriers that older adults face, just healthy older adults face. And then when you compound that with the serious mental illness, yeah, that's very difficult. And also, your answer highlights just how mental health and physical health cannot be separated.
Absolutely. And I'll just say, that is one of the to me the delights of working in an integrated primary care setting. Is that you do have the ability to break down some of those barriers because it really does take all types of expertise to care for these patients well and adequately and more than adequately to the best of our ability.
For families and clinicians listening, can you talk about the difference between normal aging and then something that might be more of a mental health concern?
Absolutely. So, like I said a little bit earlier, I think there is a common misconception that depression is a normal or inevitable part of aging. And this is not the case. So, it is inevitable that as people age, they will undergo changes. Their roles, in terms of their roles in society, their roles in their family, in their community, they will change. Their identities will change. Often, there is some physical changes that are a normal part of aging. So all of these can produce grief in a person. It is hard to change and to age, and the way that we relate to those changes can be very different and very difficult. Additionally, as we get older, we know that we are likely to lose loved ones. And so that compounds these things as well. But we also know that symptoms of depression or anxiety, such as low mood, a lack of pleasure in things that you used to like to do, so maybe gardening or going to your house of faith, having worries that you can't control and that you really can't stop, being irritable to a degree that is not warranted, and having thoughts of suicide. So, having active thoughts of wanting to take your own life. These are not a normal part of aging. And that would be an indication that a person who's experiencing any of those things could benefit from more investigation into their mental health.
Yeah, and that's great to know the distinction between so normal aging and then these signs that you want to look out for that would be treatable. So, as I mentioned, you were recently named a 2026 Macy Faculty Scholar, which is again a prestigious national leadership program supporting innovation in health professions education and an extremely selective process. Only 5 scholars are selected nationwide each year for this honor. So, congratulations, Kate. That's an incredible achievement.
Thank you so much. I'm really excited to be part of the Macy family.
So, as part of the Macy Faculty Scholar Program, I understand that you're developing an interprofessional training model for nurse practitioner and pharmacy students. Can you walk us through what that will look like?
Absolutely. Perhaps I'll just start by saying a little bit more about the Macy Foundation. The Macy Foundation is the only foundation in the United States that is dedicated solely to improving the education of health professionals. And the guiding principle of the foundation is really a strong social mission to serve the public's needs and improve the health of the public. And in service of this, they offer the Macy Faculty Scholars Program, which, as you mentioned, Monica, is a program wherein 5 physician and or nurses are admitted each year. And through the Scholars Program, they aim to identify and nurture promising early career educators in medicine and nursing as they lead innovative projects at their home institutions. The premise for my Macy Faculty Scholars Project grew from my dissertation, which, as you mentioned, I completed last year. The focus of my dissertation was on how psychiatric nurse practitioners operationalize structural competency in community mental health care. So that's a kind of mouthful, and I'm going to unpack that a little bit. Structural competency is a framework that is gaining a lot of popularity in not only healthcare, but sort of social sciences and policy in terms of thinking through how we can address what patients really need a little differently. And so, structural competency is about helping clinicians recognize that health and illness are shaped by broader social and structural forces. And using structural competency, we can help learners develop the skills to respond to that in clinical practice, to move from a theoretical understanding to embodied action. And in my dissertation, I worked with nurse practitioners in the San Francisco Bay Area to see how are they actually doing that in clinical practice, working with a population in our public outpatient adult mental health clinics that is largely living in poverty, living with serious mental illness, and living with the effects of a great deal of intersectional discrimination in their daily life. And so, one of the key findings from my research was that interprofessional team based care is essential for being able to do this in our clinical work. And that insight is what led to my Macy project. So, my project is called an interprofessional clinical program to address social determinants of health in geriatric mental health. And the goal is to create a training model where nurse practitioner and pharmacy students learn together in a variety of clinical settings to care for adults who have both complex mental health and social needs. The clinical training program will consist of both didactic portions as well as experiential clinical work. And the didactic portion will be framed by this structural competency framework. So it combines case based learning with supervised clinical experience across the continuum of settings for older adults. Our current clinical partners for this include the Department of Geriatric Psychiatry at our own institution, as well as our UCSF Care at Home program, which is the program that I currently practice in. And also, we are partnering with an adult day center in the community. And we're focusing on 3 objectives. The first is to develop a sustainable interprofessional training model. The second is to help our learners build skills in addressing social determinants of health. And then finally, to evaluate both educational and patient care outcomes.
Amazing. So, just from a sort of a psychiatric nurse practitioner in training, were I to be a part of your program, what would a day look like?
So one of the reasons that I wanted to partner NP students and pharmacy students together is, first of all, I think that both disciplines have skills and knowledge that are so important to the other. As a nurse practitioner myself, I have developed very close relationships with pharmacists over the years, and especially in our older adult population where so many of our patients are taking upwards of 25 medications a day. And I will also add that pharmacists are such an important community hub for our older adult community. I've had many patients tell me that they very rarely, almost never, leave the house except their weekly visit to the pharmacist. So there's such an opportunity for building connection and relationship through this brief encounter that happens all the time. And then I think pharmacists can learn a lot from nurse practitioner students in terms of, again, how to think through the various dimensions of what's going on with a patient and how they can incorporate that into their patient teaching and education, which is such an important part of the pharmacist role. And so the program as a student um, will involve both completing didactic modules on older adult mental health, on the social determinants of health as they affect older adults, and on sort of specific things like ageism and other types of discrimination that older adults might face when they are in the clinical environment. And then actually working in pairs with your cross discipline learners to assess and visit with older adults in these settings and come up with comprehensive treatment plans.
Incredible. It sounds like it will be such a rich experience for everyone involved. And you may have already answered this in your what you just said, but I'm curious if there's anything else you could add to the question of what will students in this interprofessional program gain that perhaps they wouldn't in traditional training.
One thing I would add is that the program provides a pretty both rare and important opportunity. I think that in clinical healthcare education, we talk a lot about both mental health and the social determinants of health together, but there are very few models for training that actually bring them side by side, specifically in the care of older adults. And while we might talk a lot about the importance of the social determinants of health in how they affect our patients, learners don't often get the opportunity to actually practice and discuss addressing them in team based care. So I really think this is a very intentional opportunity for students to get good mentorship in this area.
I think you said early something about actionable, bringing it from theory to action, and that sounds very much like what this is going to entail. For students or clinicians who are interested in learning more about caring for adults with serious mental illness, what advice would you give them?
A few things come to mind. The first is now is the time. We know that the US population is aging rapidly, and we are seeing increasing number of older adults who are living with chronic and serious mental illness. And many of these folks are navigating fragmented systems, social isolation, structural barriers to care. So if this piques your interest, are you are at the perfect time to get in on this and start making a difference for people. I would also add, I think a few things are really important in caring for older adults. And one is that it is really useful to have a solid grounding, not only in the mental health issues that older adults are experiencing, but also in the physical medical issues and how those things work together. Additionally, and commonly taken medications, as these are so deeply implicated in the symptoms that our patient population experiences. And then the last thing that comes to mind is there are so many great volunteer organizations out there that provide opportunities to spend time with older adults. So in San Francisco, we have an organization called Little Brother Friends of the Elderly, which is actually a national network of nonprofit organizations that essentially matches older adults with a friendly visitor program. And there are other things like Meals on Wheels or seniors' day centers in your community. So there's so much opportunity for you to get involved. I encourage everyone to take advantage of it.
That's beautiful. Yes, I've heard of this program, and some of the patients that I've visited with Care at Home have talked about how much they love visiting with volunteers. So, your work with the Macy Faculty Scholar Program highlights how interdisciplinary collaboration can improve care outcomes. And I'm wondering if you see a similar need for collaboration in advanced care planning, especially for older adults living with serious mental illness.
That is a great question, Monica. Thank you. I think that psychiatric nurse practitioners, all nurse practitioners, but certainly psychiatric nurse practitioners, have a really important role to play in advanced care planning for older adults with serious mental illness. We know that approximately half of older adults in the United States have completed some kind of advanced care planning, whether an advanced medical directive or a will, but that significantly fewer have documented those wishes with their primary care provider or other members of their healthcare team. And my take on that is that's because this can be a really fraught process for patients and their families. There's a lot of fear, there's a lot of anticipatory grief, There can be differences in wishes between patients and caregivers, and often there is a lack of understanding about what various interventions would entail or require. And then, of course, we also know that all providers are pretty impacted in terms of the time allotted for patient visits to really explore these topics with patients and families and address some of these issues. So, to me, this is where psychiatric nurse practitioners come in. Our whole job is to have difficult conversations about difficult topics with people, or that's how I see it. And we are skilled at holding multiple conflicting emotions and big emotions and helping people identify their values and aligning them with what they want and what they want to do. So to me, this is a very natural collaboration.
Well, your answer really resonates because as a psych NP in training, I have seen firsthand how developing trust and developing that safe space with the patient is so important for having those difficult conversations. And I can see how a psychiatric professional would be someone who's uniquely positioned to initiate those conversations, which are obviously so important. And that's a surprising number. You mentioned that only half of older adults have completed those planning conversations. But I'm going to close out actually with this is the final question for you. When you think about the future of mental health care for older adults, what gives you hope?
A few things. One is that I know that the topic of technology and older adults can often be controversial, but I also don't want to throw the baby out with the bathwater. Telehealth has made so many advances in the last few years, and although we do know that its adoption and preference is variable across older adults, there's no question that it's definitely a great tool to lower barriers to actually getting into care. And that's true of all types of healthcare and certainly mental health care. And additionally, Medicare does now cover therapy for clients. And so, even for clients who cannot leave the home, having a virtual therapist can be something that is really helpful. So, I am really hopeful about those types of advances. I'm also hopeful about the different models of care that we are seeing grow and become popular in terms of thinking through how to care best for this population. So, our model at Care at Home, I find really exciting. And I do wonder if we will begin to see a shift toward more home based or community based care in the future, bringing the care to where our older adults are at. And then the final thing is there are a lot of very caring, bright students who want to work with this population, just like Monica. And that is something that gives me hope and that really sustains me through this work.
Oh, great. It's wonderful to talk to you, and I feel hopeful just having the conversation and spreading the word about caring for elderly folks with mental health. So, thank you for joining this episode of Illuminating Health. It's been a pleasure speaking with you, and thank you to our listeners. We look forward to connecting with you next time.